Good evening, everyone. It is 5:31, and I would like to call the meeting of the Central Health Board of Managers Budget and Finance Committee to order. We do have a quorum for the moment, and hopefully we can get through our business with the quorum that is present. We will be taking the agenda in the order in which it is listed, but there are 3 agenda items that we will not take up at this committee meeting. The item number 2, discuss and take appropriate action on an agreement between Central Health and ACM Services Incorporated for asbestos abatement services and selective demolition services. Item number 3, discuss and take appropriate action on an agreement between Central Health and White Glove Excellence for janitorial services at the downtown campus. And item number 4, discuss and take appropriate action on an interlocal agreement between Central Health and the interlocal purchasing system, TIPS. These are the 3 items we will not discuss, okay? So, starting with agenda item number 1, I would like to call Jason Fournier to the front, and the agenda item is receive and discuss a presentation on the fiscal year 2019 budget for community care. And this is an informational item. We would like to keep it at about 30 minutes, and that's actually hopefully includes your discussion and questions. It's a goal, all right, so just help us with it. But thank you very much for being here. We appreciate it, and I'll turn it over to you, Jason.
Well, thank you so much, Dr. Bell and Board of Managers. It's our pleasure this evening. I'm Jason Fournier. I'm the CEO of Community Care Health Centers. And I have with me our Chief Financial Officer, Carolyn. Please introduce yourself.
Carolyn Konecny, Chief Financial Officer.
And so we'll certainly adhere to the 30 minutes. I think we've got close to 14, 15 slides we're going to walk you through. Some of them are going to be fairly quick. And so we want to go ahead and cover a little bit of a trend analysis to date so you have a better understanding of where our current year is finishing comparative to last year's budget. There's some feedback, right?
Yeah, it's a lot of feedback. Sounds better.
Test. Okay, sounds better. Yeah. Great. And so comparative to the current year in terms of numbers of services that have been provided to community members at large through our almost 30 health centers locations, and we'll talk a little bit about that. And then where we're looking at in the upcoming fiscal year, which starts on October 1st for us, we follow the same fiscal year that Central Health does as well, and talk about what our projections are and what they're looking for. Carolyn's going to walk you as Board of Managers through what our budget assumptions are and what our budget actually is looking like for the upcoming year. Just for some background, our Community Health Center Board of Directors yesterday evening approved our budget. So what you're seeing presented this evening has been approved by our Board of Directors as of yesterday evening. And then we're going to talk a little bit about how we're comparing relative to state of Texas, federally qualified health centers, and then also how we compare nationally on some of the cost initiatives that are occurring as well. So I'm going to direct, it looks like the screens just went down, so I'm going to go ahead and just direct your attention to the very first, the second slide, because the first one's as it relates to the agenda. And so as I mentioned, we currently have 30 service delivery sites. That sounds like a lot. Actually, when we look at the true number of clinics, it's 24. So some of those 30s are atypical sites. They'll include things like smaller sites where we go out at the Austin Transitional Center is a good example of that, where we're there much more infrequently, and so it's not considered a permanent site, but we have 24 permanent sites as designated through the federal government and the Health Resources Service Administration. The clinic total of 24 actually includes multiple additions over the last 12 months. So last year when we would have been presenting to you as a Board of Managers and to the Finance and Budget Committee, we had 5 less clinics. So in the intervening time, We've added well, actually 6. We added Del Valley last fall in November. That opened on November 20th, if I recall correctly. We then added Complex Primary Care Clinic, and that was a clinic that was formerly affiliated with Seton that we absorbed, and we took that over on February 26th. And then on June 4th, we added 4 obstetrical gynecological clinics formerly owned by Austin OBGYN. And so they joined our cohort of now 24 clinics as a whole. In here, we've updated our organizational charts to reflect the FTEs, the full-time equivalent employees that are within those sites and operating as they currently exist. And that's important because much of our budget, as you'll hear from Carolyn, is driven by salary and benefits for our staff as a whole. Very large. We're getting close to 880 unique employees, 860 unique employees total. And then, of course, we've got contracted providers coming to us through partners at Seton, as well as partners at Dell Medical Center, Medical School as well. What Carolyn will walk through as we look at is our encounters are really based on trend from current year and then projections in terms of new additions as a whole. And so when we take a look at some of the new clinical additions that we've got, such as complex primary care, because we're so early on into that clinical operations with us at the helm, we really did a mix of projections for this upcoming year based on the pro forma as put together financial analysis, when our board approved it, and then coupled to that, when we take a look at Del Valley and the OBGYN additional clinics that we added this year, it's really looking at the trend data that's occurred with that practice and a mix of that to date plus the pro forma. So again, complex primary care is based on the pro forma, and then the other 5 clinics that were added, Del Valley, and then the 4 obstetrical gynecological clinics were actually a mix of using the pro forma. I guess I have control here and I didn't flip, so I apologize. So taking a look at our projected and budgeted encounters. So on the far left, what you're going to see is what we projected last year. And when we take a look at, or in the middle, I should say, is what was projected last year. And then when we take a look at the far left, which is the projected amount of visits that we're anticipating for this year, you'll see that we're almost 10,000 more medical visits. Medical visits is up at the top in blue. And so comparative to what we expected to provide, we're almost 10,000 more visits comparative to what we had budgeted for this year. So that represents about a 3% increase over what we thought we were going to be able to provide last year at this time based on our budget. That also translates into unique individuals served as well. So almost 2% more individuals are being served this year than we anticipated. And so by way of example, in calendar year 2017, we served 96,398 unique individuals. We think that we're going to be, by the end of this calendar year, close to almost 99,000 unique individuals. We've got to deduplicate some folks coming from the obstetrical clinics in with our other databases just to see what that looks like long term. You can also see that in orange here is our dental visits. Current year, which ends in a couple of days, we're projecting to be at 52,500. That's roughly about 3,500 more dental visits than we expected this year comparative to budget. And then similarly on the behavioral health side, there's just a small increase relative to what we had budgeted. What's most notable is just taking a look at the far right-hand side, you'll see that the projections for the upcoming years as part of our budget demonstrates a significant increase. And so coming to the next slide, if you look at the far left-hand side, we define as a federally qualified health center much of our services on what's known as a face-to-face clinician's encounter. So think physician, think nurse practitioner, think physician assistant, think dentists, think psychiatrists, think behavioral health, and of course we've got 7 specialties now. I think last time we met, we or presented on September 5th to you this year, we mentioned that we'd added another specialty discipline to our overall services, and that was rheumatology, so that came on board. So we're actually projecting comparative to last year's budget and the projected at year end to this year in terms of our budget, a gain of almost 30,000 additional encounters. And so we're going to talk a little bit further about what those encounters are comprised of, and Carolyn's going to do that on the far right side, along the orange graphical representation here, what you can see is the percent change in total number of encounters that have happened over the last 5 years. And so when you look back to 2015 through this projected fiscal year for the budget, FY 2019, we'll have seen 20% more encounters as a result occurring comparative to 2015. So some significant growth that we've been able to provide relative to providing services within the community at large, but also coupled, of course, the support that we receive, and we're very thankful for the support that we receive through Central Health and Community Care Collaborative that allows us to provide a lot of services. The payer mix still remains very close to 52-53% uninsured, and so Carolyn's going to talk a little bit more. So I'm going to hand it over to her now, and Carolyn, please.
Okay, thank you.
Mm-hmm.
So to talk a little bit more about the encounters that Jason was talking about, so we budgeted them for existing sites that are currently within our scope. So there are projects that are being talked about, but because they're not in our approved scope at this point, we didn't put them in the budget. So you're saying, where did those increases in encounters come from then? So part of it came from existing sites where 4 provider FTEs, sometimes that's a part of a provider at a site, are being or will be added. So they're in the process at existing sites based on the organizational capacity assessment that we did. So every site was reviewed to say, could this site support more providers and therefore more patient visits? So North Central, Renberg, Southeast Health and Wellness have something in the works to add about 14,000 encounters. So good news there. And of course, the new OB-GYN sites that Jason was talking about will add about 15,000 encounters. So this is where you see a lot of the growth coming from in the budget. And then, so then once we know those encounters, then we can go with our historical information about Medicare, Medicaid, and CHIP rates. We also have some information about what payment increases will be every year, and we can project then how much revenue is driven from those using our historical payer mix. Obviously, if the payer mix changed, those numbers would change. And then our other big piece of patient revenue is the pharmacy revenue, and we projected 10.8 million. And those pharmacy revenues that we get, either from commercial pharmacy or through 340B savings, we use to support our patients when other revenues fall short. So then so that's our patient revenue section, and our other revenue section is it's the CCC agreement. So the primary care agreement was projected without an increase, so to be flat, and we're still having contract discussions with them about this. And then the other section is the district revenue, and we used the draft that's been circulated for this year's district. So this year is not finalized and it affects next year too. We used that draft to estimate what we think we would earn, knowing what we know now. So of course, as I've often said, my crystal ball is only so good. We could, it could be different. But that contract is based on 4 measure bundles, which include 27 quality measures affecting the MAP population. And you guys have probably seen presentations on this from the CCC. So that gives us our revenue. We know what our revenue is. And then our operating expenses. So we went out and got the inflation factors, and we used that for most expenses. For salaries, they're increased to reflect merit and competitive market adjustments, but no new positions. And there are no new positions because there's not enough revenue to cover new positions. The revenue that I just told you how we got it, there's not enough to cover new positions. Benefits are increased to reflect the fact that employee health insurance costs to date have been exceeding premiums paid. So our biggest benefit is that employee health insurance, and we put in a 10% increase for that, and based on our prior year's experience and what we know so far about this year, we'll be lucky to maintain that. Supplies are increased for the inflationary factor, but also to reflect those pharmacy costs, that increased revenue, those two are tied together. Contracted services is a multitude of items like lab and translation expenses and stuff like that, but a big piece of it is our joint technology expenses, and that's where we're seeing a driver increase. And then, of course, some increases for the new sites. And occupancy, again, mostly the increases reflect the cost of new sites, but also facility costs for patient navigation center and joint technology. So then you get to the page with the real numbers on it, and so, or maybe not real numbers if they don't come true, but fiscal year 2017-18 budget is to the left. Dr. Cookwood likes to see last year's budget when we put it together, so we do this for our finance committee, and so that was our budget for this year. In the middle is what we actually have projected to end this year, and a couple of weeks ago, you guys saw a presentation on current year. So this is an update of that. So you can see that we are still projecting a deficit from operations, and then the right is the budget, and we always budget a zero budget for revenue expenses to be equal, and so that's what we've done. We put together all the pieces to come out to be that, with $113,737,513 in revenue and expenditures of $113,737,513. So the next page just gives you the categories of those expenses, and you can see, looking at it, I don't think it's too hard to make the calculation that salaries, wages, contract labor, and employee benefits are the biggest expense that we have. So our people are our biggest expense. Healthcare, it's always about the people providing the care. For us, contract labor is maybe not the same as it is for other people. In most cases, it's contract providers that we have through agreements with Seton or Dell Medical School or arrangements like that. So these are contracted arrangements for provision of care, mostly providers. And that's pretty much the summary of the budget. We have a little bit of other information we put in our presentation. Cost per encounter, we compared our budget this year to our projected 2018, and you can see that our budget was $285.57. We're projecting $287.26, very close to budget. We feel really good that we controlled that cost per encounter. The draft budget shows it a little bit higher. A couple of reasons for that. One is from the complex care clinic, which has a much higher cost per encounter, much like our Arch and David Powell clinics have. And of course, also I talked earlier about the increasing pharmacy revenue, also driving increasing pharmacy expenses. So, and now I think Jason's going to talk a little bit more about cost per patient and comparisons.
I certainly am, and so I have the opportunity to kind of take it to a close here in a moment or two, but I think there's, like, you know, most financials and budgets, they're a snapshot in time. It's our best guess in terms of moving forward, but I think what you see based on last year's performance, or the current year's performance, comparative to last, you're seeing that we've outperformed what we anticipated doing this year, coupled to the fact that we're recognizing revenues. When you look at the operating loss, and a natural question that comes to mind is as well, why is the operating loss there? For the most part this year, that's attributable to timing relative to district. So you see that our actual patient service revenues are up by almost $3 million year to date, but then what we're seeing is almost $4 million less in district than what we projected last year. So that's one of the biggest drivers, and as you would imagine, we needed to work very closely with our board of directors as well as with our treasurer, who happens to be here. Dr. Coopwood is in the audience, and so we really appreciate their support in allowing us to go ahead and maintain services this year in light of some of the revenues that were not realized to the extent that we thought they would be. But when we take a look moving forward, one of the interesting things, and the subtle message that you'll tease out of this is that we're growing the number of encounters, which then directly translates into unique individuals served in this upcoming budget period as well, starting on October 1st through the end of September in 2019. And we're doing that mostly without additional investment from Central Health or CCC. as Carolyn indicated right now, at least based on our contractual negotiations with CCC, we're flat funded from last year. So the way that it's working is about $43,850,000 would be what is flowing through this year based on our agreement with them, and similarly the same amount in totality. There's different components of it, so there's no increase there. So a lot of what you're seeing here is our ability to leverage in through Carolyn's efforts, our medical leadership, our operations leadership, to leverage in other resources. And a good example of that is as we look at opportunities within our current market to expand services, to support services, also looking at the comprehensiveness of the services. And a good example of that is the pharmacy. We've seen some increases there that are allowing us then to do some other things. Most importantly, defray the cost of the life-sustaining medications for our patients, right? So there's that aspect of it. So the next slide really goes ahead. We think it's important because one of the things is a public entity FQHC that's tied to Central Health. There are certain aspects of the services that we provide, and we want to make sure that we're always looking at, well, how do we compare to other health centers? And most public entity, for those that were in attendance at the September 5th Board of Managers meeting, we provided a comparison to Denver Hospital and Health Authority, and we talked about the difference. Our costs are 12% more than theirs, but our uninsured ratio is 54.07 compared to their 14.7%. So there's a difference in terms of the mix of the population as a whole, and you may recall we discussed that. And so our costs inherently tend to be a little bit higher than most FQHCs. So what we did is we took a look at a trend analysis over the last couple of years just to demonstrate some of the cost escalation that's occurring within community health centers nationally. So this first slide is all costs by all patients served. And what's nice about this is on the far left-hand side, there's right now currently, well, not right now, as of the end of 2017, so as of December 31st, 2017, there was 1,173 unique health centers across America, of which there's over 11,000 health centers, sites, so think clinics, over 11,000 sites that are serving folks, and 27.1 plus million Americans served through a health center. Their total cost of care per patient, total patient over the last 2 years for all the FQHCs across the country increased by 13.92%, so almost 14%. When we look at Texas during the same 2-year period from 2015 through the end of 2017, Texas FQHCs, for which there's 73, increased by almost 6.5%. Community cares increased only by 2.93%, a little bit less than half of what the Texas rate increased, and nearly almost 5%, a little less than 5% of what the national average is. The next slide, similarly, this is in total cost, but this is medical cost per medical visit. So as you see earlier in the slides, I think it was slide 4 or 5, the vast majority of the services we provide are medical visits, right? And we're projecting over 270,000 medical visits this year, upcoming year. And when we take a look at that, then looking at the cost per medical visit. And so when we look at that across the country over the last 2 years, our pure federally qualified health centers are escalating at a rate of almost 9%. Here in Texas, that rate has increased by almost 5%, and community care has actually reduced its cost per medical patient, total medical cost per medical visit by almost 10.5%, a little bit over 10.5%. So those are fairly significant swings. So why are we showing this to you? Because we're very aware and sensitive to our cost structure, and we're looking at opportunities to make sure that our investments are being made as much as possible in direct service. And so that's something that Carolyn and I and our staff and our board are committed to doing to make sure that we're leveraging and maximizing the limited resources we have and spreading them as much as we can in direct service. And so so the next slide then is, well, how do we compare from a funding support from the federal government? And so when you take a look at this particular slide that's projected, when you look overall, our health center grant, it's referred to as the health center program, or sometimes the federally qualified health center. It's also known as Section 330 of the Public Health Services Act. And so Section 330, and there's a couple different sections, but in totality, that section is where the federal government gets its statutory authority from Congress to go ahead and fund the program. And so when we take a look at the average FQHC across the country, almost 18% of the funding comes through the federal government Section 330 grant program. Here in Texas, it's higher. It's almost 22%. And then on the far right, you can see we're sitting at about 7.2%. And there's a lot of different reasons for that. And it's not to say that we're underfunded comparative to others necessarily, but when you take a look at the overall amount of monies that are coming in for our underserved communities here in Travis County, the proportionality of the monies that are coming into support from the federal government directly is significantly less than our peer FQHCs here in Texas, and less than the national average as well. And so the last slide is our typical one with our mission and vision statements. So Dr. Bell and managers happy to answer any questions that you may have for Carolyn and I.
Thank you so much, Jason.
Of course.
I appreciate it. It was a great presentation, and Carolyn. Appreciate all the information. This item is a discussion item only. There's no action. So I'd like to ask the members if they have questions. I see Ms. Greenberg has her hand raised.
First of all, I want to commend you on your work and on providing and continuing to search to provide the highest quality of direct care to as many people as we can who need it. So I really want to commend you. And in fact, I'm happy that you're spending more money because that's what we want to see. We want to see more people served, and I am delighted to see that this percent change in encounters and what's happening with this in 2019. So really wonderful. The 4 providers being added, the new OB-GYN, and the encounters, commend you on that. I do note that the slight deficit in 2018, you did serve more people, because I see the encounters were higher. It was
That's correct.
356 versus 356,000 or 357,000 rounded up versus 345,000 was budgeted. And so your revenues increased, but so did your expenses. And I know it's hard to always match all that up. Is that just what happened there?
Well, it is, and part of the expense increase, and I'll ask Carolyn to chime in just a moment. So a couple unanticipated expenses.
Sure, that
Carolyn
happens.
indicated that in this upcoming budget year, we're actually anticipating a budget for a 10% increase in our health insurance premiums for our
Right.
employees.
Right.
Last year actually hit harder,
Yeah.
or higher than that. And so not just for us, for the
No,
enterprise.
the state
as
of
a whole.
Texas has been hit with the same thing, I know. Yeah.
Well, and for us because we're central health employees, it was the same thing, the same rate adjustment was for central health, for CCC employees,
Right.
community
Yeah.
care. So that was unanticipated. We had budgeted 5% increase and it came in double digit last
Sure,
year.
understood.
So that was one of them. Part of the increase in expense as well is that because we've increased our pharmacy services and we're seeing revenues to that, there's also the cost of the goods that we're
Yep.
purchasing. That was a major
course.
driver for. The other major driver of the services that are increased, so about 3% more encounters comparative to what we had budgeted, and about 2% more unique individuals served. Well, we took on new service lines that weren't anticipated
Right.
within the budget. And so the vast majority of the expense growth, besides the benefits that I mentioned, and besides the pharmacy costs, were actually for new clinics that were added throughout the year. So
Yes.
complex primary care comes in with a structure, we didn't anticipate that. So most of the increases relative to personnel expense were tied to new clinic initiatives.
Which
And-
we want to see those new
Yeah.
initiatives, and I know you can't, as I said, always match those up. And of course, the increase on the health insurance is beyond your control. But so thank you. Those make total sense to me, and I do appreciate the fact that you are providing and expanding your services, and it's wonderful to hear.
Well, appreciate the feedback, and I wanted to make sure, Carolyn, did you have anything to add to the expenses at all, or no?
Not too much. I can say that, one of those new initiatives, the complex care clinic, its expenses do exceed its revenues, so it's contributing to this.
Right.
And of course, then we have to go back to, yes, our expenses did grow along with this, but we had, all our patient revenue grew, our disrupt revenue is clearly behind what we've
Yes.
experienced
Yes.
in previous years.
Yes, we know we have a completely new scenario with Disrupt, yeah.
Well, and Manager Greenberg, you kind of alluded to the cost structure a little bit. Sometimes low cost isn't always the end game.
Right.
But
Yeah.
high quality is always the end game for us. And so
Exactly.
when we take a look at complex primary care,
Yes.
the comprehensiveness of the services, we knew going in with our partners at CCC that it was going to be a lost leader, for lack of a better description.
Of course.
But because of the intensity of the services, the healthcare delivery system is actually saving monies. We feel pretty strongly about that, and we continue to progress that model and think that we'll be in short order in a very good position to be able to demonstrate the value at a community level in terms of what that means. Now, from a cost perspective, not all of the costs or savings are ours to achieve. They're
Right,
being
I
achieved by
understand.
other partners in the community at large. So, and want to thank you guys, thank you for your kind comments, but also thank you for your support, because we do this because of what you guys do around this table. So thank you.
Thank you. You're
Yeah,
welcome.
of course.
Thank you, Ms. Greenberg. Ms. Oliver?
I have a question. So the supplies line this year, that was so high, is that part of the pharmacy project that you're talking about?
Yeah, it's almost completely
start? Okay.
pharmacy,
Got
and
it.
yes, the
Yep.
revenue does exceed the expense on that one, so.
And then one question, the total cost per patient for community care, why does it seem to be so much higher than the Texas average or the all-in average, nationwide average?
Yeah, you want to start?
I'll start and
Yep.
you jump in.
Yep.
We've got several things we think, well, first of all, we can go back to that pharmacy thing. Jason was talking about a minute ago about our high cost of uninsured. So for pharmacy then, we're providing a very robust pharmacy service, and when an insured patient gets a script at another community health center, which might be 90% insured patients or close to that, they take it to a pharmacy and get it filled. When we have an uninsured patient, a sliding fee scale patient, get a script, we're providing them the drug for a modest copay. So that's a huge part of it. We also have a few other items too that I know Jason can elaborate on.
Yeah, and so more than happy to Manager Oliver. So taking a look at our overall patient population, our patient population comparative to the average FQHC is very different. And so I'll start with Texas, because once we get outside Texas, there's enough variability. Most other states have initiated Medicaid expansion.
Right, I
And
figured
that's
that was a big part of it.
definitely changed what the payer structure looks like and resources available. But here in Texas, when we look comparative to other Brethren health centers here out of the 73, we by far exceed them in terms of number of uninsured individuals who are served. Most FQHCs that don't have a supportive hospital district that's helping support them in terms of their structure are challenged more from a financial perspective, so they're more dependent on the federal grant. But what they do then is they look at their payer mix much more aggressively from what does it look like from a Medicaid, Medicare, given our long history, not just ours, but the city of Austin, Travis County, dating back to the 1970s, when the clinic initiative started. You know, we always look towards uninsured individuals, and so that still persists today. So our payer mix is very different. We also have more individuals who are homeless, as a large homeless population, almost 4,000 homeless individuals. So the cost of providing those services, although we get a good portion of a federal grant, helps defray those costs, are significant. Another good example is we're the largest provider of Ryan White HIV services, AIDS services, not just here for Travis County, but across the Central Texas area. We do have a transitional grant award as a sub-grantee through the city of Austin that helps support that. And so most of what happens on the Ryan White side, because that cost structure is higher as well. So there's nuances to our overall population served that's very different than, say, not to pick on anyone, I won't say anyone in particular, but Health Center X that has 50-60% of their patient population is kiddos or moms. And prenatal patients, and that's just a different model.
Yeah. Thank you.
Yep, of course.
Thank you, Ms. Oliver. Mr. Jones?
I have a couple of questions. The first few are rather simple ones, being new. Over on your new, can you tell me in terms of the complex primary care, where are these facilities located? Are they operated in locations? Because I'm not familiar with all of it.
So the complex primary care clinic is in I think it's the professional office building. No, it's the clinical education building. And so that was a clinic it's on the campus of Brackenridge. So,
Yes, okay, yeah, all right then.
and so that's a clinic that was potentially going to go away.
Right.
It was previously district funded, and so with partners at Dell Medical School and CCC, Community Care absorbed that into our practice, and so very comprehensive services that we provide there, robust services. We do the physicians and mid-level practitioners that are doing advanced procedures like paracentesis and other things.
And your former new OBGYN, where are they?
So 3 here in Travis County. One of them is in Bastrop proper, so in the city of Bastrop. That was the original Austin OBGYN clinic that was established 13 years ago. And the other 3 here in Travis County, one's in Riverside, one's in Springdale, and one's in Manor.
Okay. The one in Bastrop, so how does that, are we getting any revenue or any support of any kind from?
So great question. Absorption of Austin OBGYN is a net positive revenue producer for us. So we generate excess revenue that's able to support the rest of our project given the more favorable payer mix. Back to Manager Oliver's question, the vast majority of the women that are being served are covered on the prenatal side through Medicaid, and that's more favorable for us. Manager Jones.
And over on page 7, you talk about no new positions, and I'm not sure how you all are inculcated with the expansion that is planned for Eastern Travis County. So, what is your philosophy in terms of how do you inculcate the growth that's anticipated with no new positions, I guess is right?
So, great question, Manager Jones. And so as we move forward with new initiatives with our partners here at Central Health, CCD, and others, and contemplate sites in Austin's Colony, Hornsby Bend, Colony Park, potentially looking at mobile services for Creedmoor. What we'll do is with our board, because it's not approved through HRSA yet, what we'll do is we'll put together a financial analysis, performance, and service delivery plan. We'll present it to our board for approval. And then from that point forward, then the new positions that are needed for those sites will be added as part of the financial analysis. So it's all part of our planning. At this point in time, when we take a snapshot, there was still enough unknown about what the size and scope of each one of those projects was for us to realistically be able to present something to our board as part of the budget. But our board of directors is fully apprised of the fact that we've got multiple initiatives that will move forward. So,
And I hope there's the support to be there to make them happen.
we're working on what that financial analysis looks like, and working with our partners, especially for the smaller sites, sir.
And my last question relates to on page 13, the federal grants. Your comparison between here and Texas, is this a summary of Texas, or is this an aggregate, these numbers for Texas?
So so what Health Resources and Service Administration does, it takes all the grants in Texas, rolls them up for 73, so it would include ours in there, and then it calculates what the percentage is. And then it compares what our level is versus theirs.
So if we were to de-aggregate those out and compare to other urban centers where FQs are, and look at those, would the numbers vary, or would you think it would be about comparative or different?
So the vast majority are still going to hover around 20%. And a lot of it has to do with, frankly, how we grew up as a health center within the city of Austin, as you fully know. And then as a transition, so if you have, so the tendency is a publicly affiliated or public entity federally qualified health center, on average has significantly less federal resources that are brought to bear from a grant perspective through the health center program. And those that have started as not-for-profits over the years have accumulated typically more health center funding from the federal government. So if we looked at Dallas, Houston, San Antonio, for those that are private, not-for-profit entities, they're going to have a higher proportionality. I can tell you the health center, not that the Twin Cities is comparable to Austin, Houston, San Antonio, but I think you're aware of the fact that I had the privilege of supporting the largest federally qualified health center in Minnesota, and our proportion of our overall funding was about 22% federal grant. And they started, because I'm no longer there, I'm here with you fine folks. They started back in the late 1960s, and so they had an opportunity, as you may recall, The city of Austin did not become a federally qualified health center until 1992. At that point in time, it was not grant funded, it was a lookalike. It wasn't until 2001 when the city of Austin secured its first federal grant. So if you look at People Center, for example, they've got a smaller grant as well because they didn't become an FQHC until 2012. Yeah. What?
Community Clinic, said People Centered, you mean
Oh,
People's
yeah.
Community
I was
Clinic?
going to one in Minnesota,
Yeah,
sorry.
People's
I was
Community
thinking
Clinic. I just thought that's what
Minnesota.
you meant.
So, People's Community Clinic, yes. So great questions, though.
Okay. I was familiar with some of the FQs in Houston and the differences in terms of support and federal dollars are made available, so that's why I was trying to get it that quick.
Yeah, the largest counterpart, Manager Jones, is Legacy, and
Legacy,
they're a fairly new addition
Yeah.
to the FQHC world, so their proportionality is closer to ours, but it's still higher than ours overall, but it's not the 22% or 20%.
Okay. All right, thanks very much, that was it.
Of course.
Thank you, Mr. Jones. Ms. Greenberg.
So it appears to me what you pointed out is yet again, we're unique. It's hard to do apples to apples comparisons with Central Health and some of these others to begin with because our state chose not to expand Medicaid, which means that certain tax dollars, instead of going here, of our own tax dollars, went to other states and are not being applied here to a Medicaid expansion. So there's that difference. And so when you look at us, as you said, compared to many other states where they had the Medicaid expansion, that has affected us in so many different ways, and we're hearing another one now. And then being a late entrant to the FQHC was another thing that you pointed out. So it's hard to get that apples to apples comparison. Is that what you're saying?
That is correct, yeah.
All
I
right,
think
thank
we relied for the longest time on local tax support, and still do, of course, to offset. We're fortunate that the community here has been very generous with how they've
I understand.
allocated their tax dollars.
Thank you.
Yeah, of course.
Thank you, Ms. Greenberg. Any other questions?
No questions, Dr. Chair, but just a thank you to Jason and Carolyn and to your providers. Y'all are
Absolutely.
providing great care.
I appreciate that, Dr. Zamora. Thank you.
Thanks, Jason. Appreciate it. Carolyn, excellent report.
Yes.
Thanks for your
Thank you.
time.
Thank you.
Okay. I'd also like to recognize Dr. Coopwood, who is on the board of Community Care. Thank you very much for attending and for your service. Okay, I would like to lay out agenda item number 5, discuss and take appropriate action on the ground lease agreement between Central Health and Travis County Emergency Service District 11. I'll ask Mike to provide us a summary, and then we'll ask for questions, but just to make members aware, if there are some detailed questions that you have, we'll have to go into closed session to be able to answer them. Mike Easlin?
Thank you. Thank you, members. This will be a quick update, and I'm not asking for any action this evening. You'll see us putting these various contracts as placeholders on the agenda so that we can take action should they gel fast enough. But just to let you know where we are, our respective legal counsels are reviewing the documents just to make sure that they comport, again, with our respective laws. ESD, or Emergency Services District, they have their set of laws, we have our set of laws. I think all major business decisions have been decided, so I'm not overly concerned there. One note on Emergency Services District 11, we have, as you know, the UT School of Nursing right now is the contemplated clinical lead for that site. Just by frame of reference, Emergency Services District 11 would be the greater Elroy area. And as a co-provider with UT School of Nursing, ESD 11 will also be part of that. They're also the landowner out there, but they're also part of the provider. We've recently hosted a meeting here where community care has been brought into the discussions as well. I don't anticipate that slowing anything down. I just wanted to let you all know that we're looking at bringing all of our provider partners in on this underneath that UT School of Nursing umbrella. But those are still early discussions. But again, I don't see that slowing the ground lease down. It just changes what the business model may look like that UT School of Nursing puts forward. Thank you.
Okay.
I'll recognize you, Mr. Jones, depending on what your question is, depends on whether I need to go into close, but go ahead.
I'm just right, is this what well, I guess we can't discuss it because it's a location facility. So, okay, never mind.
All right, thank you very much. Thank you, Mr. Giesler, I appreciate it. Agenda item number 6, discuss and take appropriate action on an interlocal agreement between Central Health and Travis County for certain support services, including cash management and investment services, legal services, risk management services, and television broadcast services. And I'll recognize Holly, and we've budgeted about 20 minutes for this.
So I'm hoping to be less than 20 minutes, but I wanted to walk you through the interlocal agreement that is part of your backup after the agenda items 6 marker. And this is an agreement that has been in place since 2005. So almost 1 year after the district's creation, the county and Central Health entered into an agreement for the support services that Dr. Bell laid out. Those are the cash management and investment services. And sometimes you'll see Debbie Laudermilk, who is here with us tonight, and she is crucial to performing those services for us. Risk and claim management services, legal services, and as of last year, television broadcasting services. So most of you are aware that both our budget and finance meetings and our Board of Managers meetings are broadcast on Travis County TV. So let me walk you through some of the sections so you can get a better understanding of what services the county is providing. Starting with section 1, which is on page 1 of the agreement, you'll see the cash management and investment services that are provided by the county, and that extends all the way through to page 3 of your agreement. So there's a laundry list of services that are provided by the Planning and Budget Office, and specifically the Cash Investment Management Division within that office. Then on page 3 and continuing on to page 4, the risk management services that are provided by the county are laid out. Television services, as I described briefly a minute ago, are addressed on page 4 in section 1.4. And then finally, legal services are addressed by section 1.6 on page 4. Something else that this agreement does that I wasn't familiar with until I started looking at the agreement is section 3, which begins on page 5, actually grants Central Health a license to use 4 county facilities. And at those facilities, which are described on page 18, we have eligibility workers who are there to provide eligibility services to help enroll members into the MAP and what will be the MAP basic program that the CCC operates. The term of this agreement is a 1-year term initial, and then there are 3 optional renewal terms that can be exercised, and that is described in section 5 on page 9 of your agreement. And this is a shorter renewal term than you have seen in agreements in the past. The last initial agreement we had was a 5-year renewal term, and the reason that the agreement term is a little shorter, some of you may have heard that David Escamilla will not be running for county attorney again, so his term ends in December 2021, I believe, and if I'm wrong, I will come back and tell you that I'm wrong. But sometime in 2021, David Escamilla will no longer be county attorney. And so this allows you to reevaluate the relationship with whoever comes into the office after that and decide whether you would like to make a legislative change. Some of you are aware that the county attorney is required by our Chapter 281 statute that created the district to represent Central Health. So the county attorney is required to represent you unless you change the law in that regard. Termination rights, it's a 60-day notice period. So if you were to change legislation, you would only need to give 60 days notice to the county attorney and the county on that. We have our standard funding out provision, which is on page 10 of the agreement. And then page 11 through 18 is our standard provisions that almost all contracts include about assigning the agreement, amending the agreement. I do want to make note that on page 14, section 6.15, we have included something that has not been in this agreement before, which is an acknowledgement that Central Health will comply with all laws in performing their obligations under this agreement. And the reason that that is in this agreement is because our financial policies that were adopted by the Commissioners Court require us to have that there. But for the most part, this agreement looks very similar to what it has looked since 2005. I'm happy to take any questions.
Thank you, Holly, I appreciate that. Any questions from the members?
Just one question. With the development of the district, are we required to, well, I think I have the answer, but is this the practice of other healthcare districts in the state?
The practice to use the county to
Right.
provide certain support services? Yes and no. So there are certain counties that have already changed the legislation and have their own in-house counsel that serves them instead of the Travis County Attorney's Office. But there are at least 4 to 5 districts that I am in contact with that do still utilize the county attorney or the district attorney's office to provide their advice. I cannot speak to the cash management or investment services piece. I imagine because a lot of hospital districts operate a hospital, they may do some of that themselves.
No, I'm not inquiring as to change, I'm just trying to get a history of how it operates. You wouldn't know that breakdown by?
I wouldn't.
Okay.
Mr. Beasley?
Sorry, it's Mr. Jones.
No, he's,
Okay.
you're finished.
I'm through, yes.
Members, I think just as a standard question, from the standpoint of being a board member, you want to know, are there any new obligations created under this? I mean, Holly's pointed out one for financial policies, but Counselor, if you could address that.
So the only thing that has changed in terms of Central Health's obligations are actually related to the television broadcast services. So Central Health does have special meetings from time to time, and we have been asking the county to broadcast those meetings. And so there are some stipulations about how much advance notice we need to give the county when we're going to have a special meeting so that they can make room in their television schedule to broadcast those meetings for us. But there are no new obligations in this agreement that were not in the previous agreement.
Thank you. Thank you, Mr. Beasley. Anything else? Okay, thank you very much, Holly, I appreciate it. Again, this item was only for, wait a minute. This item was for action, I'm sorry. So, I actually need to entertain a motion from one of the members. Ms. Greenberg? Number 6?
I move. He's getting such feedback, I turned it off. I move that the committee recommend the board approve an interlocal agreement between Central Health and Travis County for certain support services, including cash management and investment services, legal services, risk management services, and television broadcast services.
Welcome. I have a motion by Ms. Greenberg and a second by Mr. Jones. Any discussion? Hearing none. All in favor?
Aye.
Any opposed? Any abstaining? Motion carries. Thank you. Okay. Agenda item number 7, receive a report on the August 2018 financial statements for Central Health, and I'll recognize Jeff Knodel.
Thank you, Dr. Bell. Jeff Knodel, VP of Financial, Finance, excuse me. So sorry, retired. So this relates to Central Health's financial statements as of August 31st, 2018. Just as a reminder, our fiscal year end is September 30th, 2018. So this is 11 months into our fiscal year. So let's see. So starting, just quick highlights as we wind out through the year. One thing we want to look at is where are we at on our property tax collections. And so we look at it from a couple of different aspects. One is where are we at in accordance to budget. So we're at $181.8 million, which is 99.8% of our fiscal year 2018 budget. And then secondly, we look at the the collections as it relates to adjustment, or to the adjusted tax levy. And so we're at 98, almost 98.8%, which is consistent with previous years. I think we were a little bit ahead of previous years, but again, that's just an overall state of not only the budget, but the total due or the total levy, where we stand as it relates to that total levy. Onto our comparative balance sheet as of August 31st. Quickly going through our balance sheet, cash and cash equivalents of $1.6 million. Short-term investments are $86.9 million, which is net of restricted investments of $6.3 million of capital that you see down a little bit lower on the bottom. Our ad valorem taxes receivable is $1 million. Other receivables total $13.2 million. You see a couple of large receivables, and as we get into around our year end, we'll be looking to clear those up through intercompany balances. Both Community Care and the Community Care Collaborative are at $5.9 and $6.4 million respectively. Prepaid expenses of $947,000. Total current assets of $103.7 million. Non-current assets, not really a whole lot of change from last month or really the previous year. That totals up to $62.4 million. Our total assets are at $281.9 million. Onto the onto the second part of our balance sheet. Liabilities, accounts payable is $954,000. Salaries and benefits payable is $513,000. Other payables of $7.1 million. We have our debt service payable. This is our short-term portion of our contractual obligations at $1 million. And then a capital lease obligation of a little bit over $100,000. Deferred tax revenue of $1.1 million, and then other deferred revenue of $828,000. Total current liabilities of $11.6 million. Non-current assets, and again, not a whole lot of changes other than looking year over year, pay down of both our contractual obligations or our debt service payable and our capital lease obligation. Total of those non-current liabilities is $8.5 million. Total liabilities of $20 million. Total net assets of $261.8 million, and then liabilities liabilities and net assets of $281.9 million. On to our sources and uses as of August 31st. You see a couple of columns. You see monthly activity, fiscal year to date, budget, a percent of budget used, and then prior year to date from a comparative standpoint as of the same time period last year. Property tax revenues we talked about. We had collections of almost $184,000 this month. Lease revenue of $858,000 and other revenue of $160,000. Total revenue for the month was $1.2 million. On to uses of funds, middle of the page. Total healthcare delivery expenses were $11 million. I believe we have a little more detail on the next page, so I'll kind of skip over comments on that. And then our administrative program, we had expenses of $501,000. Sources over uses, you see we had a decrease for the month of $10.3 million, which is fairly normal for this time of period. Remember, our primary revenue source or our incoming sources are property taxes, which flow in December and January. So you'll see big positive amounts in those time periods, and then subsequently, as we collect less and less, we continue to spend, you'll see that flip over to a negative number. Our healthcare delivery slide, intergovernmental transfers, we had a small refund, about almost $110,000 in this month. Provider costs were, primary care was $103,000, and then medical administration is $51,000, total of $55,000. Healthcare delivery, we had $448,000, and then other costs related around our ACA premium subsidy, debt service accrual, and some campus development costs of $554,000. And then a risk-based capital payment related to Sendero of $10 million. Our total healthcare delivery for the month was a little bit over $11 million. And then just a recap of our intergovernmental transfer payments. You see the refund for the month of a little over $100,000 as it relates to disproportionate share. And then where we're at for our fiscal year to date and our budget. With that, I'll be glad to answer any questions.
Thank you very much, Mr. Canodal. Do we have any questions?
I have one.
Ms. Oliver?
And I feel like you answer this for me every time I am, but for whatever reason, I can't remember. What's the other revenue and why is it so high this year? Fiscal year to date compared to budget? And I feel like you've answered this for me about a million.
So other revenue,
Yeah.
we have conservatively estimated year over year kind of what our interest income has been.
Okay.
And that's primarily what's driving that, is just more interest income than what we've seen in the previous years. We've not really increased our budget historically.
Okay.
It's fair to say that interest rates have probably ticked up.
Yeah.
And then, I don't know, there may be some additional comments that Debbie may have, but I think she's done a really, I would just sum it up as saying she does a really good job of looking at what's available to invest in certain securities and what we need to hold short term.
Okay. All right. Thank you.
Thanks, Ms. Oliver. Any other questions? Thank you, Mr. Canodal. You can now talk to us about agenda item number 8, receive a report of the August 2018 financial statements for the Community Care Collaborative.
Okay, thank you. Again, this is our Community Care Collaborative financial statements as of August 31st. Again, 11 months into the fiscal year, same fiscal year as Central Health. So quickly going to our balance sheet, cash and cash equivalents of $37.5 million. Total assets for 2018 of $38.3 million. On the liability side, accounts payable and accrued liabilities of $27.4 million. Hang on just a second, I gotta get caught up here on my notes. Sorry about that. Not fast enough here. Deferred revenue of $774,000, and then other liabilities of $272,000. And then last on our liability side is accrued payroll of $558,000. Total liabilities of $29 million. Assets less liabilities leave net assets of $9.2 million. And again, total liabilities and net assets of $38.2 million. Sources and uses. Again, this is through August 31st. You see our approved budget, year-to-date actual, where we're at compared to budget, and then our prior year comparison at this same point last year. DESRIP revenue of $59.2 million. You see member payments from Central Health and Seton of $30 million and $15 million respectively. Then our contingency carry forward, which again is a carry forward from the previous year, of $13 million. Total sources of $117.4 million. Our healthcare delivery program is at $77.1 million, and we've got some more detail on that, so I'll skip over that. And then our UT services agreement payment of $35 million. And then Carolyn mentioned DESRIP. So as of August, we are right at a little over $1 million of DESRIP costs. These are costs to date. There's a high likelihood that that number will change. I don't want to say drastically, but it will increase a few fold as it relates to closing out the year and looking at where we're at for DESRIP. And it's again, just to kind of reiterate the timing dilemma that we have. Historically, our DESRIP program ended at our fiscal year, and this current year it was changed to a calendar year. And so can I call it DESRIP 2, began January 1 of 2018. And so as we look at our sources and uses, and we get into September, that would be 9 months into that period. It's really not a reporting period, and the anticipated contract that we would eventually execute has a lot of performance incentives in the contract related around outcomes. So the contract that we anticipate executing with community care will be to some degree similar to kind of the DESRIP structure and making progress on outcomes. So kind of a long-winded way of saying that there's more to come. We don't know exactly where we'll end up in September, but our hope on the CCC side is that we're paying a lot of DESRIP project costs to community care collaborative, to community care, because that means we're making progress on the DESRIP outcomes that we are performing related to that program. So year to date, sources over uses is about $4.2 million. Healthcare delivery, and I'll go through this pretty quick. As we look at service lines, primary care is our largest service line by far. We're at 87% of our budget. Overall, on healthcare delivery, we're at 75% of our total healthcare delivery budget as of August 31st. Looking a little bit more specifically at primary care, you see our providers listed out. You see we're at 87% of our budget, and community care is, again, by far our largest provider. They're at 89% of their budget for the year. Overall, we're at 87% of our primary care budget to date. Specialty care. We are at, aggregately, we're at $7.5 million related to specialty care. Couple of highlights related around specialty care. Our community care, specialty care, which were specialty care service lines that were transitioned out of the Brackenridge campus and transition into community care. We are currently over budget slightly, which I think is a good thing. We're almost at $2.2 million. You see a couple of other service lines that are over, or another service line that's over is ophthalmology, which again, we've expanded services and have really started doing a lot of cataract surgeries and needed procedures in an ambulatory setting. We've expanded that out, and then you see orthopedics, which is another service line. Even though we're at 56% of our budget, we've been providing a good volume of services related around that service line. We are at $7.5 million is our year-to-date actual, which is at 56% of our budget for the year. Healthcare operations, you see our departmental operations. Our total budget's $12.9 million. As of August 31st, we're at $7.7 million, which is 60% of our budget year-to-date. So now that was quick. I'll be happy to answer any questions.
Thank you very much, Mr. Canode. Manager Greenberg.
Just a quick comment. I don't see Dr. Coopwood here, so I will channel him at the sheer joy of seeing community care, specialty care at 110%. That means 10% over budget. That is a wonderful thing to behold. So, thank you.
Yeah, we think this is really a good thing because we've really transitioned specialty care out of kind of the BRAC campus, the POB, and have moved it out in community settings, which I think makes accessibility much greater, and community care does a great job on providing those services.
I applaud this. Thank you.
Thank you, Ms. Greenberg. No? Okay. Thank you very much, Mr. Canova. Appreciate the reports. Excellent presentation as usual. I would like to lay out agenda item 9. Take and discuss and take appropriate action on Central Health owned property, including downtown campus and adjacent properties. And we'll have an update by Mr. Giesling.
So members, Mr. Knight can join us this evening, but I want to pass along the following information. Recently it was reported that the request for proposal for demolition was public. Based on some feedback and some other inquiries, that was pulled down recently, and that will be clarified and reissued. This still has us on track for fiscal year 2019 demolition. Thank you. And then we will be bringing back in October, November actions related to abatement for environmental issues, particularly asbestos, and then the CEC alternative utilities structure as well. Thank you.
Any questions? Okay, thank you very much, Mr. Gibson. I appreciate that. Does this have to, excuse me just a moment. I'd like to lay out agenda item number 10, discuss and take appropriate action on 1115 Medicaid waiver, delivery system reform incentive payment projects, the community care collaborative, including healthcare delivery arrangements and other related community partnerships. I'd like to recognize Mr. Giesling to give us an update.
Yes. So members, my particular update concerns Emergency Services District 4, with whom we are in negotiations on a ground lease. Again, that ground lease is in a similar position as ESD 11, which is it's being reviewed by legal counsel. But the reason I wanted to bring this up under the community partnerships is to clarify how it is different from what we're working on in the greater Elroy area. Emergency Services District 4 has a station in Austin's Colony. They're off of Hunters Bend Road. And again, that we're working with them on towards a ground lease. But that emergency services district, unlike ESD 11, they have a contract with Austin Fire EMS to operate their district. I think once we get this ground lease in place, obviously, and we're working with Community Care as the lead partner on operating that clinic, we'll be bringing in integral care and other non-clinical services vis-a-vis the county over time. And this will be a temporary as we're working towards a longer-term solution out in Austin's Colony, Hornsby Bend area. That at the appropriate time, we'll reach out to Austin Fire. I know we haven't talked about this up to this point, but I just wanted to put the board on, just to make sure you're aware that even though we're working with our clinical partners, we're going to be right next door to a place that has Austin Fire EMS. And so to the extent that, I don't want to slow this down, but as we get operational out there in that area, bringing them on board as part of that partnership as well. Thank you.
Great. Thank you very much, Mr. Geisler. Any questions? Mr. Jones?
I'm trying to find the interplay between ESD4 and Austin Fire. So are they staff it, but it's still owned by ESD4, is that correct?
Yes, sir.
Okay, so the lease arrangement is with ESD4?
Yes, sir, because they own the property.
Okay, so once we have that worked out, then we'll reach the Austin Fire to talk about the interplay between us and them.
Right.
Okay.
And I haven't talked about that relationship in the same way that we're talking about the relationship with ESD 11. And recently somebody had asked me about that, so I thought I'll just use this forum here to get that out there. I've not reached out to Austin Fire EMS yet because we need to get the ground lease done,
Right.
get set up out there first. But
Okay, thank you.
Thank you, Mr. Jones. Any other questions? All right. I'd like to lay out agenda item number 11, discuss and take appropriate action on an update regarding Sendero Health Plans Incorporated, including the effect of federal legislative and regulatory actions. I am pleased to report that we had a Sendero Health Plan Board meeting on Tuesday. We voted to move forward in 2019 with the funds that were provided by Central Health, and we will anticipate and monitor the movement or the voluntary movement of the MAP patients who will be covered by Sendero in FY 2019. So I know that there are still a lot of issues that the board would like to monitor based on the motion that passed on, when was it?
Saturday.
Yeah. It's been a rough week. And we do plan to provide updates on the metrics that were outlined in the motion. But I also know that certain members have come to me expressing some additional issues that they would like to have discussed. I would appreciate if there are members that are not here, that have not approached me, that have issues that they would like to discuss, if they would send those to Emily, and then Emily can forward those to me. And I will keep a list. I would like to have a structured discussion about this, but I'd also like to have it, and I was always a little slow in understanding Mr. Geisler, but I actually think I've thought about it and I understand what he's saying. We are going to have strategic updates on big issues that we need to focus on in this year. And as you realize, Sendero would be one of those strategic issues. And so we will have that discussion, including the information that is requested through telling me that you want to talk about or have a discussion about. We will discuss those issues in our strategic session around Sendero, so that we don't have sort of a free-for-all conversation that, of course, may violate open meetings because we would probably not be on the agenda. Mm-hmm. So I'd like to structure some of that discussion and include it when we discuss the strategic updates that Mr. Geeson will put forward. Did I say that right, Mike?
Yes, sir.
Any questions?
Quick one. Do we
Yes.
have a timeline for that?
Actually, I would like, it to be.
Just begin addressing
yes.
some of these questions?
I would like to have that information come into me, no later than October 31st. We're probably not gonna get to it in the next, I'm not gonna be here for the next budget and finance meeting.
Which is, I don't know what it is.
It is the.
October 17th.
October
So-
17th.
So are you planning then in November we will get to these items? Okay. So that is 2 months from now.
That's correct. And so the sooner you, I mean, I have your request.
Right.
The
The sooner
everyone
the
can get
universal
their
use.
request in,
Yep.
it would be
Okay.
appreciated. Yes,
Will,
ma'am.
will these requests be shared with the public?
Those that we feel that are appropriate to share, if they're personnel issues, if they're issues that need to be talked about in closed session, we will not. But if we will talk about those issues that we know relate to the motion
Mhm.
and the metrics that are associated with those reports, those will be discussed in open session.
Thank you.
Okay, so I heard you, I just make sure I'm consistent with what the motion was, that we would have quarterly updates. And I'm understanding you said that between October and the quarterly updates, we will have the opportunity to engage with you, perhaps in terms of discussions on where you are or other things that have been mentioned, so that when we get to the quarterly updates, we have a complete understanding of not only what's expected in the matrix, but also other dynamics that may be going on.
Right.
Okay, but the quarterly updates will be made available.
Sure.
Okay, all right then.
Dr. Bowman.
Mr. Ortiz?
And along those lines, if we put the quarterly update out, or in some cases, I believe there's monthly requirements as well, if it looks like that we're going to be able to answer that question within that framework that you all had established between the points that you made, the points that Manager Greenberg had put in the report, then we'll let you know that as well. We will be addressing this within this report. It's really those things that aren't captured in that report
Right.
per se that we need to start
That's correct.
trying to consolidate all those questions so we can answer them as efficiently as possible.
I think, the reason I raised that question is that, everyone was at the meeting the other day, and Commissioner Doherty raised the question with regards to, he has some questions for those whose decisions were changed.
That's correct.
And certainly I felt that I was one of those that he was probably alluding to. And my question is that I'd like to be able to talk about, these are the criteria we put in place.
Right.
This is what went into us having a faith, good intent effort. And these are the mechanisms we're going to have in place to ensure that they are ongoing. So it'd be helpful to be able to say, in addition to the quarterly report, we'll be engaging about those, also doing throughout the process. So that's what I want to make sure we have in
Right,
place.
and I concur with that, because some of those items that we have in the list are not necessarily a quarterly report
Sure.
item, and any others that may help enlighten, as you said, we need to make sure that we're bringing forth. Thank you.
And is there a way to, just in the interest of, as much as we can give the public, since it does seem like we've operated so much in the Sendero realm in closed session, can we bring some things out to talk to so that they're apprised of what we're talking, I mean, I know not the super sensitive stuff like funding, I get that, but things that aren't necessarily, like, things, just to keep the public updated on kind of, again, things that aren't, you know where I'm going with this, yeah, proprietary, thank you.
Or personnel.
Or personnel.
Yes.
Okay.
And we had a discussion about that at the Sendero board meeting. We will have further discussions about looking at that type of information that we can share in open session that doesn't put the company at risk based on its the competitive nature of the business. So the board is very interested in getting and gathering that information, and then that information, once shared with the Sendero board, we can truly share it with the Central Health Board in open session.
So
Thank you.
I am very happy to hear that, because there's long been information that some of us have either wanted to have that we have not received, or that we have been told could not be available publicly. So I'm happy to hear that the board sees the need for that, the board of Sendera. Thank you.
Any additional questions, comments? Yes, sir.
Dr. Chair, may I have a moment?
Yes, sir.
I've already cleared this with council, even though we're not posted for this, but just an informational item. This week, in my office, we've already diagnosed 2 cases of flu. A couple of the emergency rooms already have diagnosed a couple of cases of flu. So to this board, to this audience, and to those watching, please go get your flu shots. Just
Can we get them now?
go wherever, yeah.
Like they're
they're-
available
They
now?
are
Okay.
available now. I got
So,
mine last week.
Dr. Bell and I are just urging everyone to go out and get your flu shots because it's here. It's in Travis County, so be careful.
And to anybody involved in education, it's just essential.
Definitely, definitely.
The student, no, but the student, whether it's in AISD, it just spreads like wildfire in those schools. You can, I seen last year, there were some that were shut down.
I also had my flu shot last week as well.
Okay, next agenda item, please.
Okay.
All right, thank you. Agenda item number 12, confirm the next regular committee meeting date, time, and location. The next Central Health Board of Managers Budget and Finance Committee meeting is scheduled for Wednesday, October 17th, 2018 at 5:30 p.m. at Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. I'd like to entertain a motion. And a second? I have a motion by Ms. Greenberg, a second by Ms. Oliver. All in favor? Any opposed? Any abstaining? Motion carries. And there is food next door if you want to stop by.
Yeah, the answer to your question,